Just to double check that you can hear and see me clearly. I'm Elvis Chimesi Abuaji, a postdoc, research fellow at the Division of Human Genetics here at the University of Cape Town. And I am your moderator for this PubGem Africa Science and Society Café. So today we will be having a conversation on hereditary deafness, a model for precision medicine in African settings. The focus will be on testing, counseling, and ethical considerations. So briefly, I would like to say that PubGem stands for Public Understanding of Big Data in Genomics Medicine in Africa. It's a bioethics project within the Data Science for Africa Discovery and Innovation in Africa, DSI Africa Consortium. So today we are delighted to have you all joining this talk. And we are grateful for you making time to join the Science and Society Cafe. So at today's PubGem Africa Harambe Cafe, we will discuss the idea of hereditary deafness, a model for precision medicine in African settings, with the focus on testing, counseling, and ethical consideration, as alluded to earlier. We'll have interveners, as you can see from the flyer, Dr. Samuel Adade and Dr. Nolutandu Mahisa, who will both reflect on their experiences as part of the Hearing Impairment Genetic Studies project in Africa. So specifically, they will be talking to perspectives in Ghana and South Africa. The PubGem Africa Cafe, this is the third cafe that is being organized, and it's guided by the African philosophy of Harambe. That is, let us work together for the common good. Therefore, we encourage all of you, everyone on this call, to use particularly the Q&A chat box, as well as the QR codes that will be shared with you to actually share your views and experiences on the topic and the themes that have been outlined. And for those who would like to have CPD points, please look out for the link in the chat. Today's discussion or today's conversation, we are privileged to have three speakers who are going to give us some insights on the topic that has been selected. So we have our first speaker, who is in the person of Dr. Hela Aziz. She's an assistant professor and lead of the Hearing Research and Diagnostics team at Molecular Otolaryngology and Renal Research Laboratories at the University of Iowa in the USA. Prof. Aziz, as a member of several ClinGen committees, she has been instrumental in establishing frameworks and guidelines for clinical genetic testing, particularly for hearing disorders, and also has been involved in the transformation of precision medicine. So we are privileged to have you, Prof, with us this afternoon. And if you are ready, Prof will be talking to us on the topic, how the advances in genetic medicine can contribute to early diagnosis, personalized interventions, improved quality of life for individuals with hereditary deafness. So Prof, if you are ready, you may proceed to share your slides, and you have the floor. Thank you. We will entreat that everyone mute his mic while the presentation is going on. Thank you.
Thank you, Dr. Abu Ghali, for this really nice introduction. And thank you, first of all, for inviting me to be part of this really great initiative. I really appreciate that. And I'm looking forward to the questions and interactions with the other panelists and also the other attendees. Today, I'm going to present an overview about the genetics of hearing loss and what and how is like hearing loss, how could we use it as a model for genomic medicine and precision medicine for hearing loss. So since the launch of the precision medicine in 2015, genetics and genomics were propelled to the forefront of disease prevention, treatment, and management efforts. Precision medicine is a shift from the standardized one-size-fits-all medicine to a precision or personalized medicine where disease treatment, prevention, and management is actually based on the person or the individual genomic data, environment, and lifestyle. What that means for hearing loss. So currently for hearing loss, for example, all rehabilitation and management is based on hearing aids and cochlear implants. But these, although they are really effective in most of the cases, they are not always very effective, and they, most important, they do not take into account the genetic makeup of individuals. So here, before we really diving into the genetics of hearing loss, just a reminder about the prevalence of hearing loss. So the World Health Organization actually estimates that are currently around 430 million individuals worldwide that need rehabilitation services for their hearing loss. And it is estimated that with improvement in longevity and the increase in exposure to loud noise, it's estimated that actually the prevalence of hearing loss would reach 2.5 billion people with hearing loss by 2050. And as you could estimate, you could appreciate from here, the prevalence of hearing loss is really different between different populations. So when we talk about hearing loss, there are different factors that would contribute to hearing loss. There are environmental causes and genetic causes. And the contribution of each of these to hearing loss is really population, let's say, dependent. And that a lot of time depends on the prevalence of infectious diseases and also the country income. So for example, for high income countries, there is a higher prevalence of genetic causes. Whereas for low income countries and middle income countries, the contribution of genetic factors decreases to around 50%. So when we talk about environmental causes, this is everything from exposure to ototoxic drugs, infectious diseases, some other biological attributes like low birth weight. There is also smoking. So there are a lot of environmental causes. When we talk about genetic causes, we talk usually of non-syndromic hearing loss or isolated hearing loss, where the only symptom the individual is presenting is hearing loss, or syndromic hearing loss. And by syndromic hearing loss, we mean any, besides hearing loss, there are other comorbidities or other organs that are involved. For example, the eye. For example, Usher syndrome, this is retinitis pigmentosa and profound hearing loss. And there are over 400 different syndromes that involve hearing loss. And we'll touch base on this a little later when we talk about the benefits of genetic testing, specifically for syndromic hearing loss. So when we talk about isolated hearing loss or non-syndromic hearing loss, this is the most prevalent kind of hearing loss. It represents 70% of hearing loss. And there are 4 types of genetic hearing loss and non-syndromic hearing loss. There is a recessive hearing loss, and it constitutes around 80% of all cases of hearing loss. And when we say recessive, usually the probants or the individuals that are affected are born to individuals that are not affected. And then to exhibit or to display the hearing loss, you have to have 2 mutated copies of the gene. Dominant hearing loss account for around 18%, and usually there is a transmission, so vertical transmission from parent to kids. And in this case, only 1 mutated copy of the gene is enough to cause hearing loss. Then we have X-linked hearing loss and mitochondrial hearing loss. X-linked, these are either the Y chromosome, sorry, I say sex-linked, either X-linked or Y chromosome linked, and mitochondrial, and these are the lowest fraction of contribution to hearing loss. And these are usually maternal transmission. So mitochondrial hearing loss are transmitted from mothers. And now here to give you a kind of an overview about hearing loss, the prevalence of hearing loss and correlated to the number of genes that have been involved in hearing loss till now. In this figure, we have the time here. So from 1993 till 2024. And then 1993, this was the first time that a locus or a gene for hearing loss was mapped by the group of Marie Claire King. GJB2, do you see my cursor?
Yes, please, we can
Okay.
see it, bro.
Thank you. GJB2 was identified in 1997. This was the first one of the GJB2 here is noted here because it is the most prevalent cause of hearing loss worldwide, except for Africa and for sub-Saharan Africa, and we will get to that later. But as what you could appreciate here, with the advent of exome sequencing and next generation sequencing, which is high throughput sequencing, the gene discovery for hearing loss really took off. And currently, we do have around 160 genes just for non-syndromic hearing loss. And here, the different colors represent the different kind of hearing loss. The blue is autosomal dominant hearing loss. And you could appreciate here, the number gene for recessive hearing loss is really the highest. This is a little more detailed overview of the genes themselves. And I wanted to show this just so you kind of accustom a little bit about the gene names. And you, again, as we were here with the advent of whole exome sequencing, the number of identified genes really increased. Otoscope was built and offered in 2012. And this is the first genetic diagnostic test that was comprehensive, meaning using screening for all genes that have been identified for hearing loss. So the first genetic testing that was comprehensive was offered in 2012. Before then, they were gene by gene sequencing, and that's how genetic testing was done. So as I said earlier, there is over 150 genes for non-syndromic hearing loss alone, and there are over 700 genes that have been identified till now for syndromic hearing loss. And if we, for example, we look at the non-syndromic hearing loss genes and only the common forms of syndromic hearing loss, there are over 16,000 reported mutations in the genes that have been linked to hearing loss. This is enormous. And that's actually what is bringing me to my next topic is genetic screening or genetic testing for hearing loss. As I mentioned earlier, before the advent of next generation sequencing, we use it to screen or to test patient one gene at a time. Since GJB2 gene was the first amongst the first that was identified, but it is the most prevalent cause of hearing loss. And because it was only one coding exon, so it's a really small, gene. We use it to screen that one in all patients with hearing loss. But that most of the time or half of the time, that's not the gene that is responsible. So we have to fall back to the next gene. And then we will used to do it gene by gene. currently with next generation sequencing, we can screen all 160 genes at once, and we can do it for hundreds of patients at the same time. So that really made genetic testing easier, and it made it more comprehensive. And when we talk about genetic testing, what it means is like we collect the blood samples from individuals with hearing loss. We obtain really detailed phenotypic and clinical information. This is very important later. I will get to it. We draw pedigrees and then requisition forms, of course, and then that sample is sent to the testing laboratory for DNA extraction. The next is a workflow, and it is lab dependent, but for the most part, these are the same steps taken by all genetic testing labs. So we're talking about DNA extractions. Then we do what we call the sequencing, high throughput sequencing. And usually genetic testing for hearing loss usually done in panels, and you hear a lot about panels. And that what it means, these are panels that encompass genes, and most of the time it's only exons of genes that have been already involved in hearing loss. Then this, as we talked about, massively parallel sequencing. Then I think the most important part of any genetic testing workflow is variant annotation and variant actually classification. So the assessment of variants. We identify hundreds of variants in each patient we sequence, and then it is up to us to really sift through those variants to try to figure out and connect the genetic data that we obtained for the patient with their clinical information to be able to make a correlation and then provide a report, what we call the results, send them back to healthcare provider or the patients. And with the report generation from the beginning, from the collection of the sample to report generation, it takes from 1 to 2 months to get the results back. And so when we do genetic testing, what is the overall diagnostic rate? So the overall diagnostic rate for genetic testing is about 45%. And as you could appreciate here, it is really ethnic specific. For, sorry, just a second. I think my, sorry, just a second. I think my battery is dying and I need to connect. I apologize for this. So, as expected, worldwide, the most prevalent cause of hearing loss is GJB2, accounting for around 20%. The very next most contributor to hearing loss is striosylin. And as you could see here, when we look at it, the 6th gene account for half of all cases of hearing loss. And this is really important. And then we will get to when we get to the panel and discussion, we will discuss this more. So, but when we look at this picture, it's not really completely accurate because here, these results are from a multi-ethnic cohort. It is very diverse in ancestry, in age of onset, in all the other characteristics. What we actually did is we went back and redid that same figure, but this time is with specific ethnicity and specific ancestries. And you could see here that the genetic makeup or the mutational spectrum of hearing loss is really ethnic dependent. Every population has their own genetic spectrum and mutational spectrum. And here we see the African American and the Nigerian population, and we got this data in collaboration with Dr. Lassisi for this population. And what I really just wanted you to appreciate here is how diverse the mutational spectrum and the genetic spectrum of different populations is. So moving forward here, As we say, this is the data I showed you earlier is from our data. But when we look at the published literature, we really see a huge disparity in the published literature on the genetics of hearing loss. And you could appreciate here that for most of the African continent, we do not have a lot of data about the genetic of hearing loss there. So there is a huge opportunity there that to investigate and really invest into deciphering and understanding the genetics of hearing loss in Africa. This is a work that has been done by Dr. Adidi in 2022, and it is actually showing the genetic spectrum of hearing loss in the African continent. There are for North Africa, for example, for Tunisia and Morocco, there has been a lot of work that has been done on hearing loss, and the mutational spectrum is really well established. It is not the same for other countries. There is, for example, I know for Cameroon, for Ghana, and from South Africa, there has been a lot of studies investigating the genetics of hearing loss. So what actually we could see from this work is GGB2, although it is the major contributor to hearing loss worldwide, it is not a major contributor to non-syndromic hearing loss in most of sub-Saharan African populations. We also noticed that variants in MYO15A, this is another gene, and it is the second most frequently reported hearing loss gene in both North Africa and South Africa. And then they also actually identified a founder variant in MYO7A. And MYO7A is linked to Usher syndrome. And this variant was identified in patient as a founder variant in South Africans, Black South Africans. This is another work from Ghana, from Dr. Wonka. And they did also, here I'm just showing, so it is not for comprehensiveness, so we won't have the time to go over all the data that has been published. But here, really surprisingly, they found a diagnostic rate of 51% in patients with hearing loss from Ghana. And they found actually that cadherin23, that is CDH23, and MYO15A genes are the most prevalent genes in these populations. So this is just kind of an introduction and passing to talk about the next panelists, what they are going to talk about. So why do we need, or someone asking, why do I need genetic testing? So the first thing is going to be an answer to why. Why does my kid, or do I have hearing loss? For a lot of parents, answering this question is really giving them relief that it was not their fault. Because a lot of times parents think it's somehow they did. For example, the mother, it's something she did during a pregnancy, and that's why her kid or her kids do have hearing loss. So that providing answer really provides relief and alleviates the guilt and some misconceptions. It also kind of end of the diagnostic odyssey, because sometimes if we do not find the cause, we just keep on testing and more testing. And this is time consuming, but it also costs a lot of money and a lot of exhaustion actually from parents and kids. So it really provides a diagnosis, which is great. It ends the diagnostic odyssey, and it might avoid invasive procedures. Another benefit of genetic testing is it really provides a prognosis. And it means, what that means, it can tell you, once you have a genetic diagnosis, whether, for example, the hearing loss is going to be progressive, whether it's going to be stable, whether it is going to be progressive and it's really fast rate. Another thing is it will tell you about comorbidities. What that means, a lot of syndromic hearing loss at the beginning, or when the patient is really young, the only manifestation they have is hearing loss. And this is because the other symptoms will develop with age. So when they are a newborn or the first few years of their life, they only have hearing loss. And if they do not do genetic testing, they would not know, for example, oh, they have a mutation in a gene that cause a syndromic form of hearing loss. So they might lose their vision. They might develop a heart condition. They might have bone disease. They might have renal disease. So it's really important to provide that information about comorbidities to parents. It also genetic testing is also great at providing accurate recurrence risk. So if we test and then we know there is a recessive gene, whether it's mitochondrial gene, this actually changes the recurrence risk for future pregnancies and for future kids. And also this information is really empowering, as it will offer parents the choice actually for reproductive, whether what they can do for their reproductive planning and options. The other thing is access to support. Once you are diagnosed, there are a lot of support groups worldwide about the specific gene or the specific disease, and that is really helpful to families to address some of the daily questions and daily struggles. And one important thing is also access to research. And for example, for clinical trials or for gene therapy, no patient can actually register or can actually access these trials without genetic testing diagnosis. They do have to have genetic diagnosis to do this. And also for people, let's say, for example, they do undergo genetic testing and it is negative, it actually also, they can be offered research. And it means that the researcher, the lab, can continue working on that family and involve them in research, so to identify, for example, novel genes or novel mutations that we couldn't identify previously. And I will go just a few examples here. I don't know how much time I have left, but I will try to go fast. Just to show.
So, Prof, if you can be winding up, we'll have much more time for the discussion aspect.
Okay.
So just about 3 minutes will do. About 3 minutes will do.
Okay. 3 minutes. I'm good. Yeah. So this is just to show you a few examples of the benefits of genetic testing and how it offers actually genomic medicine or precision medicine. For this case, we got this case as 2 kids. They have a mild to moderate or severe hearing loss, and they have completely normal medical examinations. And then we identified 2 mutations in ASH2A. And this is actually really important because these kids are now going to be followed for their vision too, so not just hearing loss. In the second case here, we have a patient with bilateral profound hearing loss, and the clinical exam and the clinician, when they sent us the sample, said this has Usher syndrome. So when we tested them, we could not find any mutations in Usher syndrome genes, but we did find 2 mutations in SLC26A4, which explains their profound hearing loss. And we found 1 mutation in OPA1, which explained their limited vision. So that changed the diagnosis from Usher syndrome to actually 2 different diagnoses. The last one is a case with bilateral hearing loss and renal dysplasia. And the clinician doctor, when they sent us, they said this person has Bohr syndrome. Bohr syndrome is a renal and hearing loss. So when we did genetic testing, we actually identified the mutation in the GATA3 gene, which is not involved in Bohr syndrome at all. This is involved in hypoparathyroidism. So it is a completely different diagnosis, and we were able to correct the clinical diagnosis. And this is really important because their management now is completely changed. And then the last one is going to talk about, the before last one is NLRP3. And then when you identify a patient with NLRP3 mutation, you can actually offer them canakinumab. And this is a drug that will actually ease and prevent or sometimes even reverse their hearing loss. And the final thing, I don't know if I bet everyone heard about it, is gene therapy for otoferlin. So this is the first successful, actually, clinical trials gene therapy for hearing loss. And the only way you can qualify is if you have genetic testing. So if you, and everyone all over the world are on now screening patients for otoferlin mutation, so they can be able to qualify for the clinical trials. And that's it. Thank you. And then I'm looking forward to all your questions and the discussion. And I'm looking also forward to hearing from the other panelists. Thank you.
Great, Hella. So thanks. I will move on straight. So I will still encourage our participants to put their questions and also share their views on the link that has been shared in the Q&A. So kindly write all your questions. We'll address the questions during the discussion time. Thank you very much, Prof. So move on to our next speaker, who is in the person of Ms. Malebu Malope. She is a clinical genetic counselor at the Tygerberg Hospital here in Tygerberg Hospital in Cape Town, South Africa. She's also a lecturer at the Division of Molecular Biology and Human Genetics at Stellenbosch University. And at Stellenbosch University, she is actually coordinating the teaching activities of clinical genetics unit, and she has special interest in accessibility of genetic counseling services, issues that has to do with equity, diversity, and inclusion in clinical genetics. So Ms. Malepo will speak to us on how we can promote inclusive and shared decision-making in genetic counseling for hereditary deafness in Africa. Thank you. So you may go ahead, please. Thank you.
Good evening. Thank you for inviting me for the talk. Can you please just let me know if you can see my slides?
Yes, please. And we also appreciate if you can put your video on for us. Thank you. You can see
Oh, sorry, I
slides
can't. I'm having bad network, so I think I should keep it off for bandwidth, and then I'll try when we're having the discussion to switch it on.
That's fine.
Because just now it had kicked me off. So today I'm just going to talk about promoting inclusive and shared decision-making in genetic testing for hereditary deafness. But I'm going to take it from the approach of just providing the underlying information and sort of theoretical framework, and hopefully we can discuss more on the topics. I'll be looking at a few important definitions that we need to remember when looking at hereditary deafness, culture and what deaf culture is, decision-making, and then also what informed consent is. So when we're talking about inclusion, we have to focus on what does inclusion actually mean, and also we have to think about equity, because as you can see from the previous presentation, not many people in Africa have access to genetic testing. The numbers were quite low when they showed the map. But then we need to think about then what is inclusion in genomics, and it's ensuring that there's fair and just distribution of benefits and opportunities related to genomic healthcare, and that we're removing all the systemic barriers and biases that impede other people from benefiting from science advancement. And another important thing is then equity in general. And I'm just going to use this image here on top, on the top left, where they're showing equality, equity, and reality. And we know for people with disabilities, including people with hereditary deafness, in reality that they don't have access to the same resources that other people do in terms of genetic testing, and also just resources that they need on a day-to-day basis. And what we need is actually equity for them, so that we can actually put them on the same level playing field, which is here in the middle. So with equity, what we're saying is that some people need to be treated differently for them to have a meaningful equality of opportunities. So where do we need to place them, and what more should we give to them compared to other people? And we must be able to integrate them into society, but more than integration, we need to be able to be inclusive, which is looking at our image here on the bottom left. You can see inclusiveness means that We are having sort of systemic reform in creating accessibility, physical and emotional, and promoting a sense of oneness with the people or with the organization that the people are in. And especially when we're doing things like genetic testing for them, being inclusive, having the resources that they need. Do we have a sign language interpreter? All of those things being made available to them in our aim to be inclusive. And then we're looking at culture, and culture is very important because especially when we're looking at the African continent, everyone comes from a different kind of background, and Africa is quite diverse with ethnicity and also genomically. And culture is an integrated pattern of learned core values, beliefs, norms, behaviors, and customs that are shared and transmitted by a specific group of people. But when we're looking at cultures, that we have our core culture, which is usually related to our ethnicity, sometimes also related to your religion or where you are geographically. And then we have things that we call modifiers. So what is modifying your culture? And it can be all these kinds of things. And when I think about my culture, I know that in my culture, we have certain kind of music, food, behaviors, rituals, customs. There's a language that we speak. And this is the same thing that applies to people with deafness, is that they may have a core culture that belongs to their own ethnic group. So we do have deaf people who are part of the Xhosa population or part of the Zulu population, part of the Bedi people. But then there's also something called deaf culture. And what I like is that people asking themselves certain questions like, what do you know about deaf culture? Are you willing to learn? And how can you be more inclusive towards people with deafness? And coming to this, and I went on this website, which is called the National Institute for the Deaf, and it's a South African website where they actually explain what deaf culture is. And when we're talking about deaf culture, we write it with a capital D because it refers to their way of life and doing things as part of their own community. And they also have their own way of doing music, art, drama. I mean, I've watched a few TV shows where they're showing like deafness music and how they do music and performances and comedy. So they also have their way of life. And according to this definition, but remember in culture, things can be a little bit fluid, but they were saying that it's someone who's not using sign language as a primary way of communication, integrating predominantly with the hearing community. And in this context, it just means that they do not identify with the deaf community and they perceive deafness as an impairment. But with people from the deaf community and the deaf culture, they use sign language as a primary way of communication. They're immersed within what deaf culture is and what it offers. And for them, it's a socio-cultural perspective. And what we have seen previously is that with deafness, it was interesting for me because some people didn't even mind having children who were also deaf because that's just a normal way of life and they have a culture and a way of doing things. And there's certain things that are done in deaf culture that may be opposing to the culture of the people who are hearing. So certain things like eye contact, which is extremely important for the people who are deaf or hard of hearing. And also remember, some people are able to lip read. So that eye contact is quite important so that they can look at your facial expressions and read lips if they need to. Touch is not seen as something that you can't do with someone, especially if it's appropriate. So you may touch someone if you want to get their attention. Physical proximity differs because when you have a hearing community, I can literally sit right next to my friend and be able to communicate with them. But for them, it's important to think about physical proximity so that they're able to communicate, especially if they're using sign language. If they need to read your lips, they can't do it being too close to you because they need that space in between. And they tend to be quite direct, which can be seen as them being blunt. And they're not usually being blunt, they're just direct, and that's how they communicate. And other things such as thumping on tables and floors to get somebody's attention, which we may sometimes perceive as being rude, but for them it's completely normal. So when you're providing genetic counseling or when you're trying to communicate with people of the deaf, these are things that you need to keep in mind, that they have certain behaviors that are appropriate for them, which we may deem not to be appropriate. So in summary, in terms of the culture part, we need to remember that people have a core culture and then they have a subculture, which would be like community level. So the deaf people might have a culture that belongs to their family, but they may have a culture that's related to them. And all these other things around them may modify this culture, but also culture is fluid. So someone may identify with being part of the deaf culture, but still identify with whatever their ethnicity or their cultural background is. And now we're looking at decision-making because we want informed consent, but informed consent can only be done through proper decision-making process. And even as a genetic counselor, even other people, I know in some places we have lay people providing this decision-making to help people make decisions regarding genetic testing. It's always important to think about yourself so that you can be able to understand the patient in front of you. So you think about, how do you make a decision? Who do you involve in medical related decisions? Do your religious or cultural beliefs impact that? And have you ever felt like a healthcare worker is not hearing you and understanding you? And what would have you liked for them to do better? And then all of this then brings us to two concepts, which is shared decision-making. And in the next slide, I'll explain collective decision-making. And shared decision-making, it's usually one between the healthcare professional and the patient. And the patients are encouraged to think about the available care options and the likely benefits and harms of each to communicate their preferences and also help select the best course of action. And genetic counseling usually is quite non-directive, where we don't really choose a direction for the patients, but there are situations where we know there is treatment and you can explain the benefits and the risks and also explain to the patient and let them also communicate, because the important part of this being shared is that it's not just me as a genetic counselor communicating what I want the patient to hear, but also for them to communicate what they'd like to say to me. And the different components of shared decision-making, it's at least two participants, as I said, the physician and the patient. Both parties share information, both of them take steps to build a consensus about the preferred treatment, and then agreement is reached. And collective decision-making, on the other hand, goes hand in hand with autonomy, because we all believe in client autonomy and that our patients or clients have to make the best decisions for themselves. But we have to remember that in a non-Western culture, people can be organized in a collective manner, and they may appreciate making a collective decision rather than making a decision alone, hence making autonomy, like individual autonomy, a culturally limited concept, especially with genetics, because more often than not, it has implications for other family members. So when your patients come alone, it is important to ask them if they want their families to be involved, their partners, and also thinking about that some people may have actually never learned to make a decision alone by themselves. And although we try to encourage them that they can make this decision alone, sometimes they want somebody else to be there with them, and that is okay, and we should always make provision for it. And we also have to think about that with collective decision-making, superiority, inferiority may play a role. And also think about who needs to be consulted about healthcare in the family. In some families, the matriarch of the family would need to be spoken to. This could be the aunt, it could be the grandmother, it could be their mother, in terms, because this is their healthcare, and especially if you're going to need more information. And also thinking about the hierarchy of the relationships between the healthcare professional and the patient themselves, especially coming from an African context. They may show what we call polite submission and respect, and just agree with you when you're trying to do the shared decision-making and not really expressing themselves thoroughly because they were told that you must respect your healthcare professionals, show respect, show politeness. So just encouraging them to also participate in the decision-making. And then we come into informed consent, because you can't have shared decision-making, you can't have inclusion without having proper informed consent. And informed consent is the process in which the healthcare provider educates a patient about the risks, benefits, and alternatives of a given procedure. And in this case, it's about testing. And the most important thing is that these 5 criteria should be met. So firstly, are they competent to make the decision? And as we heard from the previous presentation, is that some of them are syndromic and can lead to intellectual disability. So if you know that this is an adult person, however, they have significant intellectual disability, their caregiver needs to be present to be able to help make this decision. And are they making this decision voluntarily, or are they being forced to make the decision? And most importantly, you need to disclose everything regarding the testing. So you need to talk about things like what is known, what is unknown, what do you think the differential diagnosis is? What are you testing for? And also discussing possible results, because patients need to know that sometimes there's no result, they don't find any variance, and it doesn't mean that it's not genetic. They need to know about variances of uncertain significance, pathogenic variants, benign, all of this stuff. They need to be able to understand it before then they can give you the authorization, which means that they're giving permission for the testing. And when we're facilitating this decision-making, you need to keep in mind certain things. So you have to identify which parts of it is difficult for them to make. Why is it difficult for them to make this decision? Do they understand risk and risk for future generations, for themselves, for other family members? What emotions are they feeling? And I know that sometimes it can be quite difficult working with an interpreter, but as someone providing the service and you're seeing a lot of people with hereditary deafness, then it's important for you to also start learning sign language. I saw an occupational therapist who actually taught themselves South African Sign Language in a period of 6 months so that they can communicate better with their patients. And it's great because seeing how her journey has been, because majority of her patients will be patients with hearing loss. So discussing all of those when you facilitate, you're doing that as an additional layer to facilitating decision-making is quite important. And then just using scenarios. So we use analogies all the time to explain genetics because it's quite complex to understand for the regular person who hasn't done genetics, and also possible outcomes. See where there's disagreement, especially if someone is coming with a partner or their spouse or their family members, address that and say, I see that this is a disagreement. Why do you agree? Why do you disagree? And see if you can reach a midpoint. And so then you can give other stuff to help with decision-making, and we call these decision-making aids, and they can come in various forms where they're also given printed, written out information, videos to watch, but obviously they must have subtitles. Audio media can be quite tricky, especially if people have hearing loss, but if you want to do it, then is it for the people that are able to hear, who have cochlear implants? What is your plan around that? And also giving them internet resources. But this information should be information that's going to help them to actually make a decision. And also patients then from that information should be able to communicate their values to their practitioners and also increase their ability to be making a collaborative decision, whether with themselves and the healthcare professional or them and other family members. So that's another thing to think about, is that yes, we want to have the genetic counseling session, but in the meantime, if there's information to share with them that'll help them think about their condition and genetic testing. So this is my last slide on factors that can affect the decision-making. Most commonly, it's the client's characteristics. So family support, if there's cohesiveness in the family values, gender identity, knowledge, concerns for needing certainty or not, because some people are very happy not having a genetic test, but also certain experiences that they have had, either their own personal experiences or being the sibling of someone who's had hearing loss, and whether or not they're considering testing. And remember that siblings can have a different experience. We've had a clinic where one sibling wouldn't mind having a child with a certain genetic disorder. However, the other one feels like it's something they could not do because they were the older siblings and saw all the hardships that their parents went through. So these are different things that could affect them, and also whether or not they want to reproduce, if treatment or screening is available, that sometimes encourages people to have testing, and also if the decision maker is not there, the decision maker within the family, and then just risk perception and perception of community stigma to or not to test, especially within the hearing community. I mean, the deaf community, remember I did say that for them, it is a culture. And if you want to move away from that kind of culture, they can feel a little bit isolated if they personally feel that that is not the environment they would want to have a child within or have a child with the same condition. Thank you.
Thank you very much, Ms. Malebo. So we will move, before we move to the third presenter, Otopen, are you able to share? If not, let me try from here.
Yes, I am. Let me, okay.
So I'm coming. Are you able to share so that I'll leave you to share, because then you take it straight away. Then I'll do the introduction. So our third speaker is Ms. Jemima Finn. She is from Ghana, a clinical audiologist at the Kolebu Teaching Hospital. And she advanced hearing therapy practice training from the UK. And based at the referral facility, she actually is involved in carrying out diagnostics tests, hearing tests and assessment, and also managing people with hearing impairment, usually referred all over the country, including a
teen test, just for, I think, those that are undergoing the trials and all that, or research, but hopefully very soon be able to go through and get it as a routine assessment. Yeah, so our sense of hearing enables us as human beings to communicate with other people and foster our social interactions. It allows us to forge relationships just like we are doing now. This is my first time here, so for other people. So we are forging relationships, we are communicating with each other. It helps us also to participate in daily activities for ourselves and for other people that we are related to, and also helps us to be alert to danger. So whether to fly, run away, or we have to face the danger, our sense of hearing helps us to know that. And then also we experience life events like birth, marriage, death, and all that through hearing. And then we are able to attain life's goals academically, economically, because our sense of hearing is available for us. So hearing impairments, in sense, is the most frequent sensory impairment in humans that has significant social and psychological implications, as from the previous slide. And then impact on hearing loss on a child growing up into adulthood can be seen in the following areas: delayed language and development in communication that leads to poor literacy skills and sometimes cognition. And then also academic underachievement, because even though the child might aim to go as high up in the ladder, there are quite some constraints, not from their side alone, but in terms of societal provision, the constraints are great. Then there's also social isolation, because it's not able to communicate or match up with their peers. So they tend to isolate themselves and try to find one or two that they can relate well to. Have higher risks for injuries, because there are some sounds that you might not be able to hear, and for you to move away from the danger or curb the danger. And then we see that there's altered long-term employment opportunities due to inability to attain probably the level that you want to attain to get the best job that you want to get to, the education you want to get to. And therefore, you have to settle for lower income jobs, and thereby increasing poverty, because there's also high dependency. And then we see that there's altered mental health and then low self-esteem. The causes of hearing loss, I'll not go deep into that, but we know that prenatal period, we have genetic factors, both hereditary and non-hereditary. During pregnancy, mother can also contract infections, use unregulated medications that may lead to hearing impairment. During the perinatal period, that is during the period of birth, there can be issues that might affect the child and then can affect the hearing, because the ear is one of the senses or the systems that is highly affected by lack of oxygen when labor is prolonged. And then also exposure to infections. Then across lifespans, we have other things like infections, systemic infections, ear infections, trauma. All these things are things that would precipitate hearing loss, or causative factors. And then when the hereditary factor is there, it adds up to it. Aging, that we cannot run away from also. Some people, as they age, they tend to lose their hearing, in some families more than others. So these are some of the causes. What are some of the WHO facts on hearing loss? About 430 million people, that's 5% of world's population, have disabling hearing loss, out of which 34 million are children. And so this number is expected to rise up to about 700 million by 2050. And this leads to the global burden of unaddressed hearing loss being estimated at about USD 980 billion. And we see that a higher percentage of this is in Africa because, I say Africa, low to middle income countries, of which Africa, most of the countries are part anyway. And because of constrained resources that we are not able to use to help people with the hearing impairments, get them to the optimum level that they can get to be self-dependent. Then about what good news is that 60% of these childhood hearing losses are preventable. And so as much as possible, if we're able to curb some of these things, we know that the numbers will go down. Early identification has been seen by WHO as key to managing the impact of hearing loss through screening across ages from newborn to adulthood. And genetic counseling is listed as one of the effective strategies for reducing hearing loss. And so this webinar is in the right direction as we see how best we can move genetic testing forward. Genetic testing in Ghana. I would want to acknowledge Dr. Adade so much because once you search for genetic testing, his name pops up, and we are so proud that he's doing so much work. And so we look to get to the top of all the research that is happening. So in Ghana, they've reported that non-syndromic hearing loss is found in Ghana, and the trace that is seen, that's the connexin 26, to use the simpler term. So that's the founder mutation in Ghana, and has a relatively high population carrier frequency of 1.45% among the healthy Ghanaians. And so it's a cause of worry that we need to identify people and then be able to manage earlier through genetic counseling, testing, and all the factors that we can to help reduce the numbers as we go up. So Adade and co found that though some form of newborn hearing screening is carried out in Ghana, genetic testing for those who fail the testing is not yet in practice. So there's no working document supporting genetic testing yet, and WACBIP has come up with proposals to policymakers and implementers to promote genetic counseling as part of the newborn hearing screening. So we are looking up to the promotion of this policy document and for it being adopted as a working document for this genetic testing to come through. So what are the aims of genetic testing for hearing loss? So it supports early identification and intervention for those who fail the newborn hearing screening. And so when we add it to the test battery that we do for diagnostic assessment, we'll be able to get a definite diagnosis for the patient so that the appropriate management will be done in good time. It will also help us to reduce unnecessary costs of clinical testing. You are doing MRI, you are doing CT scan, just to find out where the lesion is. So when we're able to do genetic testing also, we'll be able to provide insight into other related health conditions that may not be obvious in the normal testing that we do in the clinic. And then it also leads to an understanding of the cause, what is causing the problem, and the progression of the hearing loss that the patient has to the professional who is managing the patient. It will also inform patients and parents on the chances of passing a particular condition or occurrence to other children, and then they may inform themselves. I have one patient who the daughter, I think the first daughter, had hearing loss, profound hearing loss, and so we've had to do cochlear implants for her. And then the second daughter is okay. Currently, the first daughter is about 6-7 years. Now she's on cochlear implant for the 2nd year now. The second daughter is okay, and then she got pregnant again, and then she herself reported that she can't feel the baby, that he doesn't respond to sound. And lo and behold, she gave birth, and we did the testing, the hearing assessment, and the child has profound hearing loss. So for such a person, could have benefited from the genetic testing, so that it will inform the choices whether to have more children or to whether she wants to have more children or whatever, if they are okay with what they have now, in order not to raise the burden. So currently there has to be another cochlear implant for the newborn, and you can imagine the cost of cochlear implantation in Ghana. And then it's also a more objective way, since it may not always be scientifically correct to rely on inheritance patterns to identify disease. So these are some of the aims of genetic testing for hearing loss. And then in terms of approaches to hearing impairment, whether we are doing screening, that is, we are moving to the patient, or the patient reports to you for an assessment, we need to be guided by ethical principles. And so current approach to healthcare delivery has moved on from the traditional model of biomedical model to a more patient-centered care. And words that we can use to describe patient-centered care include safety, equity, effectiveness. I think our speaker before me talked brought a few things to light on this. Integrity, timeliness, and person-centeredness. Core element of patient-centered care is shared decision-making, which is very important, and we'll talk a bit about it. So the shared decision-making has been established that there's a link between evidence-based healthcare and shared decision-making. And when we are talking about shared decision-making, it's defined as integrating individual clinical expertise with the best available external clinical evidence and compassionate use of individual patients' predicaments, rights, and practices in making decisions about their care. So if we have to underline, we highlight clinical expertise, we highlight external clinical evidence, and then we highlight individual patients' predicaments, rights, and practices. So all these things will come to play together to be able to make a decision about the patient's care. Ethical principles that underline and underpin healthcare delivery that most of us are aware of, we need to bear in mind the right to autonomy. So the person, at the end of the day, the decision lies with the person to make of the course of action, whether for good, for bad. The person has the final decision to take. And then we should have justice, fairness in distribution of health resources. Already we are constrained with resources, and so preferencing will come to play. It's very important for us here, so that we'll be able to share, we'll be fair in the distribution of health resources. So we have to bring into light preferences, patient preferences. And then there's non-maleficence, we do no harm. So anything that we are doing for the person should not bring untoward harm, either now or in the future, to the person that we are attending to. And then there should be beneficence, which everything that we are doing should bring benefits to the patient, even though we might not know what is best for the client, but we aim or achieve this by combining research and then preference from the patient. In shared decision-making, there's silent misdiagnosis. So we as clinicians are excellent at medical diagnosis, and we seem to be on top of the patients. I am the professional, but this refers to misdiagnosis because we might not know what the patient really wants about their health. And so we need to be trained in what we term preference diagnosis, which relies on use of indirect and complicated ideas which may not be chimed well with our own ideas. And to achieve this, we require listening and communication skills. So it's very important for us as professionals to have this, to be able to have the patient's preference known. And sometimes, especially for examples in hearing care services, we give hearing aids to patients who are not yet ready to use the hearing aids. They'll tell you they use it, but they keep it in the cupboard because they are not ready, because maybe we didn't go to the bottom of it for them to come to terms and agree and understand. And so, yes, they have expended money, but they will not use the hearing aids. So people hold their own preferences for the outcome and treatment options, even though it may not be best. So we need to learn how to get to the bottom of this to be able to achieve the goal that we want to achieve. Some of the skills, just about, I think, the last slide, some of the skills required for shared decision making in genetic testing, we need to acknowledge patients and clinicians as a team. So there should be active participation. We should be able to listen to our patients. So we start from establishing preferences, then we go to the pros and cons, where the clinician will be on top, because you know the options available and the treatments and the outcomes available. Then we both come to a conclusion as to what best will work for the patient. It might go either way, and there's no win-win situation in this, but for all, we want the best for the patient. And then informed consent, as my earlier speaker elaborated much on, needs to need to get the consent of the patient or the one responsible for that person, the consent before you take action on the agreement that has reached. And then providing privacy and confidentiality of information is very important. Results must be accurately interpreted so that there will be no misconceptions. And then once outcomes come, we need to avoid discrimination against the results, or discrimination against the patient, because now we see the patient in another light. And then continuous offering of counseling and support to the person is important. And then sometimes we are limited as to what we can do for the person. We refer appropriately to help the person to make the most out of the person. So in a nutshell, these are some of the ethical considerations we have to take when we are going through genetic counseling. And we look forward to moving on with this genetic testing in Ghana. Thank you so much. These are my references that I used. Thank you very much.
Thank you. Thank you very much, Jemima. So at this point, I think we'll have to kickstart the discussion. Then as we move on, we'll bring in our other interveners. So I think, Jemima, please, can you stop sharing your screen?
Oh, yeah.
And
Okay.
just have your video on. That will be great for us. So interesting point and interesting highlights coming from the patient. So we can clearly pick out from Hella highlighting the population diversity that has been explored, then also how important there is a need for this genetic testing, or let's say precision medicine, to actually complement clinical diagnosis. Then we look at also Malupe also bringing in the aspect of the counseling, inclusivity, shared decision making that has been, whether our patients are well informed to make informed decisions, then also the cultural norms and other perspectives, and also Jemima coming and adding on with the ethics aspect, as well as the social implications on for policy guidelines and also recommendations to guide the advancement of precision medicine. So I'll put this question from my point before we move to the Q&A. I will also entreat everyone on the call to put your questions or your views on the Q&A. We'll actually read them out for the panelists to address them. So like combining these three areas that I've actually spelled out, it has to follow any order. It can be either from Hela, Jemima, or Malebo responding to it. If there's a concern that fine, we know precision medicine is where we are approaching. So when we come to the African perspective, what are the current challenges in implementing precision medicine approaches? When we take, for instance, hereditary deafness in African communities, what would be your take to share on that? Maybe we can start with Prof. Aziz. Thank you.
Okay,
Sorry, can you hear me?
Sorry, who did you want to
Can you
start, Elvis?
I was saying, if you can share your perspective based on what has been projected so far, on what are the current current challenges, current challenges, trying to put my video on, current challenges in implementing precision medicine approaches for hereditary deafness in African communities.
Yeah, that's actually a really great question. And it also applies, you know, to Africa as well as the other countries worldwide. And it is really challenging. One of the challenges, I think, to realizing the promise of precision medicine is democratizing genetic testing and access to genetic testing. A lot of communities do not have access to genetic testing. So genetic testing is really, like, the cost is exorbitant. That's like a huge cost to do genetic testing, because we no longer do the gene by gene. It has to be comprehensive. And next generation sequences is expensive. It requires tools. It requires instruments that are really expensive to acquire, really expensive to maintain, and also to have the skills. You know, people operating them have to have the skills. So I think those costs are really kind of challenging and hindering for a lot of low and middle income countries. That is one. The second thing is, I think, is the disease awareness of the population and education of the population. There is a lot of stigma surrounding hearing loss or any other genetic disease. There is a lot of stigma surrounding this, and it is for so many reasons, but also, you know, oh, if it's genetics, then other people in the family would have it, which means it's now the stigma to the whole family, not just the person. So I think there need to be a lot of education, a lot of awareness, and reaching out to populations, reaching out to schools, reaching out to communities to let them know, to educate them about genetic testing, about you know, all the benefits, not just, you know, looking at maybe the negative or the things that are perceived as negative. So I think these are, in my opinion, these are kind of the most important things to consider. And I don't know what the other panelists think. I would like to let them talk too.
Yeah, I think that's a fair point. So maybe Jemima or Malebo may take it from the point of accessibility. How do we make it accessible? We know the technology is there. How do we make it accessible to, okay, go ahead, Malebo, please.
Thank you very much. In terms of accessibility, we must first, and everything that was just said now is correct. And in addition to that is, what does accessibility mean? And do people actually understand, and are they able to engage with the information? Because if we want people, for example, to enroll in the different projects that are trying to get genomic data on this and have testing so that hopefully they're going to have precision medicine for them of some form, it's important to also keep in mind that the communities need to understand what it is that we are doing, and also making sure that we are trustworthy. Because I remember when I was still in the hygiene project and we're recruiting participants with hearing loss for Limpopo, it wasn't just they were going to recruit at the different schools. The whole process was, first I went to the schools to speak to the principals of the schools and understand them. And they also told me about the parents, what the parents are expecting, how I can present the information to them. Because remember, I'm an outsider in that specific community. And then they did all the liaising with the parents, brought the parents there. Some of the principals helped us to communicate, but we actually had parents that then, once they understood, helped us to recruit other parents in other different regions to find families. So I think it's just building that trustworthiness, but also being trustworthy. So if we're collecting your information, explain to people, what are you doing to it? Who will have access to that information? And should other studies arise, are you going to come back and research? But the most important thing is feedback of information. Are we going to feedback the testing from research? When should they expect that research? Because communities actually, many of them for other various genetic conditions, some of them are reluctant to keep participating in different genetic related or health related projects because nothing comes back to them. And we can't just keep getting this genomic data but not feeding back the results. Even in diagnostic settings, people knowing what has been tested, the impact of it. And we often think there's no terminology that the people can use, but if you learn the languages of the people, there might not be a specific word for gene, but there could be a word for hereditary. And people have an understanding of what hereditary is if we just take the time. So it's being engaged and immersed within the communities that we want to have access to this, because if we're not, then it doesn't help, because we want people to be able to give informed consent, and being informed meaning that they understand everything about the project, and also just being trustworthy individuals. Yeah.
That's a valuable insight. So I think before I will let Sam and Nolu come in, Jemima, you made a very interesting point that has to do with our healthcare systems and also the role of government in line with policies and guidelines and frameworks that actually should be put in place to actually advance precision medicine or its application even in research. So if you'll be able to say a word or just your take on how, or in your thoughts, the role of government and healthcare systems in providing the support and resources for individuals affected, particularly with deafness, when we are talking in African settings in terms of precision medicine. What do you think are some of the roles that governments should put in place, and some frameworks? What was the way forward coming from a referral facility? Emma.
At the advocacy or accessibility from the government sector or the policymakers and implementers. So in terms of these programs, most of the time we have what support that comes in for a limited time. And so the programs flourish for some time. But when the support ends, what do we see? We see that a lot of these programs die down because the government has not come in to own the programs as the people's program, so that they can provide funds and then provide means and guidance and policies to support these programs. We've seen a lot of these for us trying to raise this newborn hearing screening and aspects of hearing assessment and accessibility to devices. It's been quite challenging able to get documents to support hearing care in Ghana. So we as those who are lucky to be in this area, we need to continue our advocacy. We need to bring out our research and go to the government and say, hey, this is what is happening on the ground. So what is the result of our research saying? We are seeing people getting deaf, and the numbers are going to grow because we are not doing anything about it. So the government will be there, and they will not act because nothing has come to their doorstep and they are not willing to go out there. So we as those who are working with the people, now it becomes a burden on us to move up and try as much as possible, whatever links that we have, to be able to go to them, present it to them, and then be on their necks to be able to take up what we need to get our services given to our patients and then make it accessible to everyone. So that's what I think, that there's a lot of work on us, a lot of burden on us as advocates.
Thank you. Thank you very much. I think it's a valid point. We need to bridge the gap between research and also policymakers. It has to take a collective approach going forward. It can never be independent. So wherever we are missing as researchers, wherever. Sorry, so that's an interesting point. Then we would like to have a word from our interveners. So Dr. Nolutandu Mayinsa and Dr. Samuel Mauli Adade were part of the hearing impairment genetic studies in Africa for South Africa and Ghana, respectively. So Sam, I will start with you. If you can actually give us some thoughts on how best to incorporate genetic testing in hearing impairment in Ghana. And will you consider it's based on your experience, what you did based on your report so far, investigating families, whether it is a good model that can be implemented for other conditions in the African settings? Thank you. Can I please, can we all have, the panelists have our video on, please?
Okay, thank you.
Please, on, not off, on. Thanks, Sam. It's great to have you.
Okay, thank you so much, and thank you to the organizers for organizing this program, and also for the people who presented early on. In actual fact, Jemima has touched on all the points I was going to talk about, but I will just reiterate some of them and also give some life examples. Going to patients, going to their houses, meeting their families, one key question that they keep asking is, so after you identify the cause, what next? Is there hope or chance for my child to hear again? And these are the kind of questions we've been hearing from families. But looking at what is happening around, I would say that we already have the roadmap for precision medicine in terms of hearing impairment or hearing loss within the Ghanaian population. We started by first understanding the context. So we did prevalence studies, we looked at the impact on the society, we looked at genetic factors that are associated with the condition. Then we went on to do awareness, building of awareness and education, which fortunately our chairperson, Dr. Elvis, has led that arm of the research for some time now, building awareness, developing of a docudrama and all that. So one thing that is important for us to do in Ghana to help with precision medicine and the incorporation of testing for hearing loss in Ghana would be the infrastructure and resources. So we don't have the infrastructure yet built to support this kind of work, but I must say that there are other things coming up within the country which is building momentum towards this. And a good part would also be to integrate within the existing healthcare system. So we need a primary care referral system, everything working well so that we can integrate into the healthcare system. Then we need also to work on ethical, legal, and social considerations. So we need Malebo and your colleagues to help us within the Ghanaian population. We don't have the ethical framework fully outlined in Ghana. So we need that. Who owns the genetic data when we have it, and what we should do going forward. Then there are other things that other people have spoken about. And one thing that we also need to consider is the accessibility and equity. I would like to maybe stop here, but bring out this question, which might trigger our discussion. So some of the deaf people that we talk to, some people are just are very comfortable with the condition, and because it forms part of their culture and it's a community they are living in. I remember after one of our presentations, someone asked the question, so are you coming to eliminate the deaf community? That's the question the person asked. So in line with this, people who are comfortable, people who don't mind giving birth to hearing impaired children, how should we approach this as hearing individuals, first of all, researchers, and also clinicians, such that we are non-directed?
Okay, that's also a great topic to actually, the discussion will actually continue. We can definitely explore everything, but that's a very fair point to raise. So Nolu, to actually give you, Nolutandu, to give you, we've actually run out of time to give you, let's say, 2 minutes to actually speak, because you've also been part of this hearing impairment genetic study. If someone asks you, what will be your justification for us to consider hereditary deafness genetic investigation as a model for genetic testing in Africa, what will be your justification?
Basically, I think that Professor Hader has actually touched on this, which would be your diagnostic, diagnostic conclusion of what's happening or the cause of the hearing impairment in the family, because one of the issues that always came up is, where does this come from within a lot of the participants in South Africa? So who's to blame? What happened? Where this is the first time it's happened within our family or within this community. And with the genetic testing, it means that, okay, fine, when we sit with the families and with the communities, the first thing we need to do as researchers is explain what hearing impairment is and what the genetics surrounding hearing impairment is. So you explain that for some patients, it's actually going to be your environmental factors, but with other patients, it is a family condition or a hereditary condition, and then explaining the different types of hearing impairment. So the genetic or the model of genetic testing is more based on understanding of hearing impairment than the end goal of the research, where the research actually comes secondary to the communities.
Okay, thank you very much. So this has actually been a very interesting discussion. So all the questions that have been put on the Q&A, we'll try as much as possible to, I think majority of them has been covered. There's one question that has to do with which deafness has been cured. So Prof. Aziz actually referred to the most recent gene therapy, and it has to do with the otopharyngeal gene. So it is now, although the number, that's very few, about 6 children in China, but it's promising. So it's promising and looking great that they've been able to cure using gene therapy. So it has to depend on the gene first, and now at least they have a proof of concept. So the concept is there, but it also has to depend, the type of defective gene is also very important. If it's otopharyngeal, then the role model is there. So Nolu, I'll come back to you. So I will just want to wrap up with this, then now give each and every one time, maybe 30 seconds to just some final words, because we've already gone beyond our time, so that will be in time. So Nolu, maybe your 30 seconds can start.
I think maybe with the question regarding who it can be done with, remember with hearing impairment is that, or hearing is a learned skill that is learned over time. So when you're thinking about cochlear implants, hearing aids, you always want to do it in a patient who is as young as possible, so that they can learn how to hear and learn words and sounds and all of that. So with that question, it's not necessarily specific age, it's about rehabilitation and how much they have learned how to hear in order for it, maybe for the management to actually work.
Thank you. That's a fair point. So the age point, I missed that one. Thank you very much for bringing that up. Sam, your maybe 30 seconds.
Okay, so I would say,
Hours.
yeah, I would say that for hearing loss, we do have hope of restoring hearing, and we've seen the evidence and the impact. So for our communities, especially the African community, we need a lot more education. We need a lot more awareness creation. And we should also fight the stigmatization so that we don't make it look like it's a curse or it's improper for you to have a child with hearing loss. Thank you.
Okay. Thank you very much. So Malebo, your last words, 30 seconds, your take-home message for us. Thanks.
Pardon? Sorry, I didn't get that.
So we just wanted to have your last words because we are almost done with our time, as we've exhausted our time. So your last words before we bring this meeting to an end.
Okay. No, I think the important thing is seeing your patients as people also, and that they are the co-creators of their own life and also experts of their own life and their condition. And when communicating that with them, give them the confidence that they are able to make these decisions regarding genetic testing, and that you may know better in terms of healthcare, but you don't know what's best for the patient. And I think keeping that in mind when doing it. Thank you.
That's great. Thank you. Thank you very much. Jemima, please, your last word in 30 seconds.
Okay. So
Sorry, Prof. Prof,
I,
can
as
take
a
it up.
clinician, I would look forward. So getting it as a part of our this thing, diagnostic assessment, because people come to you every time and you're not able to give them answers because from the history, we've not been able to get to know what the cause is. So I look forward to that. Would be based on our government doing more. So we'll push WAGDIP to do more advocacy for us, to do more research so that we'll be able to get the government to have their ear to genetic testing and then help us in our scope of work.
Thank you very much. And Prof, your final words.
Thank you all. It has been a great. I learned a lot and it has been fantastic. I think our field, there are a lot of challenges and there will always be challenges. But I think seeing you and seeing like the motivation and the passion with which you talk about all of this, the future is bright. And I really can't wait to see all of you. And I also, like, just a final thing, I would love to see you involved at the world stage. Please, for example, if you would like to join the ClinGen hearing loss expert panel or any panel, let me know and you can join. We really need to hear the voices of Africans. And that's the only way, you know, we can convey what we have done in our continent, what we would like to do. And I'm really excited about the future. Thank you.
Thank you. Thank you very much. So I want to use this opportunity to also thank all our attendees. Thanks to everyone making time to actually in the spirit of the Harambee. And we also want to inform everybody that the next cafe will be on the 27th of this month, and it will be on the topic ethical and responsible data science for infectious disease surveillance and research in Africa. So, and you can also follow us on all our social media handles. And the discussion is not ending here. As Prof said, we will try and keep in touch and so many interesting points has come up from genetic diversity, infrastructure. We even talk about it. We can even talk about data generation and sharing when it comes to Africa. Even how do we empowerment our participants? We empower them to be able to make informed decisions. Then we move to the frameworks, as well as even when it comes to the cultural norms and the values, even in the family. What happens to somebody who doesn't want to know the information about whether the person carries a genetic risk or not? It comes back to Malebo, your point that you raised. So these are interesting points that we are actually going to push and maybe engage the expert and or the all stakeholders to be able to push the precision medicine when it comes to the African settings forward. So thank you very much. We thank everybody for making time for this. I'll see everybody again, or look forward to see you all again in our next cafe. Thank you very much, and bye-bye to everyone. Thanks.
Thanks, bye.